Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. I am so excited today because we'll discuss many cardiovascular and respiratory system vignettes, and of course we'll answer them and explain why this specific answer is correct. Warning, these are very challenging cases. They are not for the faint-hearted. Let's get started. This video is brought to you by TrueLearn QBank. These cases are from their website. The cases are so good and they provide answers, explanations with many summary tables, and in many cases, you can watch the Picmonic or pictured mnemonic animation in the description under the vignette. You can use the link in the description box to try them for free. Now to the cases. With each case, please pause, read it, and try to answer it yourself. Now, pause. So we have a 50-year-old woman, lost consciousness, fatigue, fever, night sweat, diastolic murmur that is best heard at the cardiac apex. What's that? If you say mitral stenosis, you are correct. However, it changes in frequency as the patient shifts position. Interesting. This murmur was not there in her last visit. What is going on? First, here are my murmurs. Mitral stenosis is here. It's a diastolic murmur because it starts after S2. So it's in diastole. Usually has opening snap and then the diastolic rumble with pre-systolic accentuation followed by a loud S1 of the next cycle. So the patient has the murmur of mitral stenosis. This is the mitral valve right here. But why does the murmur change in intensity as the patient changes position? Because she has atrial myxoma. It's a tumor in the left atrium. As the tumor moves back and forth, back and forth, back and forth, as the patient changes position, the frequency and the intensity of the murmur can change. This is a space-occupying lesion for sure, which can lead to what? It can lead to blood stasis, which is part of Ferko's triad, increasing my risk of clots. If it happens in the left atrium, it's called thrombus. If it leaves, it becomes an embolus. Left atrium, left ventricle, aorta, brain, causing what? Symptoms of low cardiac output. So the complication that can happen is embolic stroke from the heart to the brain. The key here is that the murmur sounds exactly like mitral stenosis, but changes in frequency as the patient shifts position. Case 2. Please pause and read. I have a 71-year-old guy. We have 3 hours of severe substernal chest pain. ST elevation in 2, 3, and AVF. Probably an inferior wall myocardial infarction. And we have hypotension, as well as some jugular venous distension. But the lungs are clear, with no murmurs. What's going on? I hope you memorized the Beck's triad for cardiac tamponade, which is jugular venous distension, hypotension, and distant heart sound. This patient does not have cardiac tamponade. This patient has a right ventricular infarction, which is a similar but not identical triad. Right ventricular infarction is jugular venous distension, hypotension, clear lungs. Why? Because only the left side of the heart can ruin the lung due to back pressure and backflow. Suppose that I have a left ventricular infarction. The left ventricle cannot pump, so blood will stagnate and pile up and pool in the left atrium, and then pulmonary veins, and then lungs, causing pulmonary edema, pleural effusion, cough, hemoptysis, wet crackles, etc. But when the right side is destroyed, it can never ruin the lungs. Hashtag clear lungs. How did you know it's right ventricular infarction? Do we have other clues? Yeah. Please remember that the right coronary artery is responsible for supplying the right ventricle and the inferior wall. That's why we had ST elevation in leads 2, 3, and AVF on ECG. So the same artery that supplies the inferior wall supplies the right ventricle. Since we know that the patient has a problem in the inferior wall, it's not a big stretch to imagine a problem in the right ventricle. When I have infarction in my right ventricle, do you think my right ventricle can relax and expand during diastole? No, the right ventricle is toast. So what's going to happen to my preload or end diastolic volume? It is decreased. The preload is the input to the heart. If the input is low, the output is low. If the output is low, I'll get hypotension and I will suffer symptoms of decompensation. Case 3. Please pause. What do we have here? We have an old guy, again, underwent coronary angiography, very important. That's an invasive procedure that is poking my artery. He has all kinds of risk factors that you can imagine, and now there is something new. BUN is high and creatinine is high, so we have a kidney problem. So how did this procedure trigger a kidney disease? Let's talk about that. This patient had atherosclerosis. We have all the risk factors. Atherosclerosis makes my artery narrower, increasing stasis. And according to Mr. Ferko with his triad, what do we get? Clots. First, I get a clot here. That's called a thrombus. And then it dislodges. Now we call it an embolus. Until it reaches the renal artery or smaller vessels and destroy my kidney, elevate my BUN and creatinine level in the serum. What do we call that? Cholesterol embolization, also known as blue toe syndrome, except in this case it did not happen to his toe, it happened to his kidney. So the correct answer here is atheroembolic disease. Next, case 4. Please pause and read. We have progressive weakness and difficulty breathing. It is chronic. He has tuberculosis. His pericardium is thickened. What's that? TB pericarditis. He got tuberculosis in the pericardium around the heart. Remember the difference between primary tuberculosis and secondary tuberculosis. Primary tuberculosis can only affect one of 4 organs. Mostly it's the lung. But secondary tuberculosis can affect any organ in your body, such as the heart, causing pericarditis. Here is my heart. Let's imagine that this is the pericardium. Now it has tuberculosis, so it's thickened. I have infective pericarditis right now. Do you think the heart will be able to expand during diastole? The answer is no. So what's the correct answer? Lack of diastolic expansion. But hey, medicosis, why not reduced ventricular compliance? Great question. First of all, what's compliance? It's the change in volume over change in pressure. The reason why this is not the case is because the disease is not in the myocardium itself. The myocardium of this patient is healthy. The problem is in the layer that surrounds the myocardium, aka the pericardium. Translation: do not blame the ventricle. The ventricle is fine. It just happens that every time the ventricle tries to relax, it's surrounded by a thick tissue, so it cannot. Case 5, please pause and read. What's going on here? He has erectile dysfunction and he's taking a new medication. Interesting. And then the green appears blue to him. Also the yellow appears blue to him. What's that called? This phenomenon is called cyan, which means blue. That's why we have cyanosis. Opia, vision from optic. Cyanopia. What's the name of the medication that can lead to cyanopia? If you say sildenafil, you are absolutely correct. So the answer here is inhibition of phosphodiesterase 5. Normally ATP becomes cyclic AMP thanks to the adenylate cyclase enzyme. But who's gonna take cyclic AMP to the cleaners, i.e. degrades cyclic AMP? Phosphodiesterase. Do we have medications that act as phosphodiesterase inhibitors and therefore increase the level of cyclic AMP? Yeah. All of these, including sildenafil, which is a phosphodiesterase 5 inhibitor. Recall that when I take sildenafil, what's going to happen? Cyclic AMP increases, which increases the contractility of cardiac muscles, but decreases contraction, i.e. causes relaxation of smooth muscles. That's how it lowers blood pressure. That's how it treats erectile dysfunction. And here is the mechanism. Sildenafil right here inhibits phosphodiesterase 5, cyclic GMP goes up, protein kinase G gets activated, and then phosphatase gets activated. You break down the phosphate by a phosphatase to become myosin light chain without a phosphate, which causes relaxation of smooth muscles. Sildenafil can also lead to cyanopia. Next case, please pause. We have a young patient, fever, productive cough, difficulty breathing. Not up to date on his immunization. The voice is muffled, sitting in the tripod position. Stridor is heard. What's that? This is acute epiglottitis. Organism, please. Haemophilus influenza B. How can we grow it on culture? If you say that the answer is hematin, you're not correct. If you say the answer is NAD, you're also not correct, because we need both. Each one of these on its own is not gonna make H. influenza grow on culture. Who can make it grow on culture? Staph aureus. How come? Because Staph aureus is beta hemolytic. Staph aureus comes with its hemolysis zone on blood agar. Blood, so it's providing hematin. And Staph aureus hemolysis also provides NAD. So the answer is D. Case 7. Please read and pause. So we have two stories here. In the first story, here is my blood culture or blood agar. The organism grew. So now I know that I'm dealing with bacteria that can grow on blood agar. But then I did the experiment with some modification. I added vancomycin, colistin, and nystatin. What's that called? This is thiamartin. Remember VPN, vancomycin, polymyxin, or colistin, and nystatin. What does thiamartin medium do? It kills everything except Neisseria. So if I look at the dish and I see bacteria growing, I know it's Neisseria. Did the bacteria grow? No, it did not. So it's not Neisseria. What else can grow on blood agar but not on thiamartin? If you say Haemophilus influenza, you gotta give yourself a round of applause. And if you have watched my previous videos in my Picmonic playlist, we have talked about Neisseria before. Neisseria is gram-negative. Here is the devil. Diplococcus, double-cocked eyes. Neisseria love to grow on chocolate agar. Thiamartin medium, VPN, vancomycin, polymyxin, or colistin, nystatin, which will kill every bacteria except Neisseria. Next case, number 8. Please pause. The patient is unresponsive, tachycardic. Mucous membranes are dry. Here is a medicosis way of dealing with questions. Whenever they give you sodium and chloride and bicarb, you have to calculate the anion gap even if they didn't ask you. The anion gap equals the positive on one side minus the negatives on one side. What are the negatives? Bicarbonate plus chloride. My sodium is 140 minus bicarbonate is 18 and chloride is 101, giving me an anion gap of 21. Is this high or normal? This is high, so we call this high anion gap metabolic acidosis. What are the causes of high anion gap metabolic acidosis? Mud piles. So let's run down the differential. But before we do that, what else is going on? Creatinine is high, BUN is high. Here is another medicosis way of doing things. Every time they give you BUN and creatinine, you gotta get me the BUN to creatinine ratio. The BUN here is 25 and the creatinine is 1.8, giving me something like 13.8. If this number is greater than 15, do not blame the kidney. If it's lower than 15, as we see here, blame the kidney. So this patient has kidney disease. Now let's run down the differential of Hagma and see which of these will destroy my kidney. Methanol. It destroys my eye, but not kidney. Uremia. Well, could be. However, I don't think it's the original problem. Also, uremia cannot be treated with any of these. D. Diabetic ketoacidosis. No, because the glucose is normal. P. Propylene glycol. I have no clue. They didn't give me any hints here. Iron or isoniazid. I don't think so. Lactic acidosis. He's not feverish. I don't think he has sepsis. Next, ethylene glycol. Can this damage the kidney? Yes, of course. It can lead to kidney stones. It causes kidney damage. And what's the management of ethylene glycol intoxication? The answer is fomepizole. Look at that. If I leave ethylene glycol alone, it will be metabolized to glycoaldehyde, which will be metabolized to glycolic acid, which is toxic to the kidney, as in this patient. How can I stop this? Give fomepizole because it inhibits alcohol dehydrogenase, which is necessary to metabolize ethylene glycol. Case 9, please pause. What's the clue here? The clue is that we have repeated attacks of asthma exacerbation. That's high yield. Transient bilateral pulmonary infiltrates. And eosinophilia. And bronchiectasis. What's that? Allergic bronchopulmonary aspergillosis. I have a video titled Allergic bronchopulmonary aspergillosis on my channel. Remember we said before, history of asthma or cystic fibrosis, not responding to treatment, chronic cough, mucus plugging, usually described as brown sputum plugs, eosinophilia, recurrent transient lung infiltrates is allergic bronchopulmonary aspergillosis. I adore these cases. Here is case 10. Please pause. What do we have here? We have a patient with lung symptoms. He works in demolition. As you demolish old buildings, what's going to come out? Asbestos. And he's a smoker. Most of you thought of asbestos and went to one of these choices for mesothelioma. Not true. Asbestosis is more likely to cause primary lung cancer rather than mesothelioma. So you're saying that asbestosis does not cause mesothelioma? No, I did not say that. The question is asking about the most risk, and the highest risk is for lung cancer. That's number one. After that, the second malignancy is going to be mesothelioma. Please recall that your respiratory system, such as your lungs, is derived from the endoderm. Case 11. Let's go. Pause. Alcohol use disorder. Poor dentition. Dental cavities, gingivitis. Submandibular lymphadenopathy. Presents with lung disease. What happened? If you say this is Actinomyces israeli infecting the lung, you're absolutely correct. And it's famous for causing these rosette shape. You know what are these? These are the filamentous branching bacteria known as Actinomyces israeli, and you can see them here as well. Recall that Actinomyces are branching, anaerobic, non-acid fast, chronic granulomatous infections, colonies of filamentous microbes, oral abscesses, dental infections, dental cavities, and before you know it, it can go places. It can infect my lungs. Case 12. What's that? Here I have a farmer. While working with hay, what happened? Cough, chest tightness, dyspnea, fatigue, bilateral diffuse crackles. What's that? Hypersensitivity pneumonitis. Which one? Farmer's lung. What's the trigger? Thermophilic actinomycetes. Case 13. Please pause. We're doing a cricothyroidotomy here. Which of these structures are we piercing? Now look at this doozy picture from TrueLearn. Incision pathway, cricothyroidotomy, let's go. First, we pierce the skin, and then superficial fascia, and then deep fascia. After this, the fascia of the infrahyoid muscle. After that, the pretracheal layer of the deep cervical fascia. Pretracheal because we're just in front of the trachea or trachea. After this, it's very important. What do you call the membrane that is between the cricoid cartilage and the thyroid cartilage? Cricothyroid membrane? Genius. And before we know it, we are into the trachea. Intubate the patient, give oxygen, help the patient breathe, save the patient's life. Please notice the difference between this membrane, which is cricothyroid membrane, and this one, which is thyrohyoid membrane, way up here, not in front of my needle at all. So what's the answer? It's not thyrohyoid. Thyrohyoid is way up there. Cricoid cartilage, I did not pierce the cartilage. Prevertebral fascia, I pierced the pretracheal fascia, not the prevertebral. So no. Superficial cervical fascia, yes I did. Thyroid isthmus, I did not touch the thyroid gland. So the answer here is D. These questions are at a whole other level. Case 14. Shall we pause? We have an old guy, cough, weight loss, smoker, probably lung cancer. Yes, we found a mass. It's probably a cancer. Biopsy results are here. What's the most likely diagnosis? Please notice that the mass is peripheral, not central. So this is not small cell lung cancer, and it's not squamous either. And they said that it's part of the lateral wall of the lung, not the pleura. So mesothelioma is out. Is it carcinoid? Carcinoid affect the bronchi, more central. So how about no? We're left with bronchoalveolar carcinoma. If you watched my video on lung cancer, we talked about bronchoalveolar carcinoma. It's the old name. Today we call it what? Alveolar carcinoma in situ, which is a subtype of adenocarcinoma, which is peripheral, and the most common lung cancer type in adults. Case 15. Please pause. Most students unfortunately said African American female, therefore it's sarcoidosis. Wrong. Did you read the question? Did you look at the DLCO? DLCO is normal. The diffusion limit of carbon monoxide is normal. Remember that DLCO serves the same purpose as the AA gradient, but in a slightly different way. The moral of the story is, if the DLCO is normal, it means that the lung is normal. But if the DLCO is low, then we have a lung disease. The breath sounds are clear bilaterally, and the DLCO is normal. The patient's lungs are normal. Is sarcoidosis a lung disease? Sure. Therefore, sarcoidosis is not the correct answer. You gotta choose something that does not affect the lung itself.
Okay.
And from these labs, what do we get? We get a restrictive lung disease.
So you want restrictive lung disease, and the problem is not in the lung itself?
Yes, indeed.
How come?
Maybe it's a problem in the diaphragm, like diaphragmatic paralysis. Maybe it's a problem in the chest wall. Maybe we have kyphosis, or scoliosis, or kyphoscoliosis, or ascites, or pregnancy, or obesity. That's the answer. Recall that restrictive lung diseases are divided into two groups. Extrinsic restrictive, do not blame the lung, i.e. DLCO is normal, versus intrinsic, blame the lung, DLCO is abnormal. This patient had extrinsic restrictive lung disease caused by obesity. Here are the causes of low DLCO. As you see, these are lung issues. DLCO is normal if my lungs are normal, or if the problem is outside the lung, like a chest wall disease, like obesity, like diaphragmatic paralysis, like ascites, like myasthenia gravis. Next, let's go. Shall we pause? Ovarian cancer, mother, ovarian cancer, sister, endometrial cancer. What's that? This is a hereditary cancer disease.
Well, no kidding, Captain Obvious.
But which one? If you say Lynch syndrome, you're absolutely correct. And Lynch syndrome is known as hereditary non-polyposis colorectal cancer. Here are the manifestations or the cancer. Here's the name of the disease. Here's the gene mutation. Ovarian cancer, endometrial cancer, colorectal cancer, no polyps, with no or few polyps. Skin cancer, what's that? Lynch syndrome. The gene mutation is in the DNA mismatch repair.
Hey, Medicosis, this is a cool picture. Where did you get it from?
From TrueLearn, of course. Look at those. Hereditary breast ovarian cancer syndrome. We have BRCA mutation, which literally stands for breast cancer. We have Coden syndrome, Leaf-Romani, Lynch syndrome with colorectal, endometrial, ovarian, as well as Peutz-Jeghers syndrome. And this is part of TrueLearn's explanation under the previous vignette. So, out of today's 16 vignettes, how many have you answered correctly? If you answered all of them correctly, we gotta talk. 12 to 15, excellent. 7 to 11, pretty good. Less than 7, it's never too late to change careers. There is dignity in any occupation. I'm just messing with you. I know these questions are very challenging, but practice makes perfect. Why do I like TrueLearn.com? Because they have questions for every exam you can imagine, even for practicing gynecologists and anesthesiologists and all kinds of students. The questions that I showed you today are from USMLE Step 1 preparation. Use the link in the description box to try them for free. TrueLearn.com has thousands of questions. You can sort by the degree of difficulty of the cases. And it's not just easy, intermediate, or hard. They actually give you a scale between 1 and 10. Choose how difficult you want your questions to be. And of course, you choose your system, your subject, your discipline, area of competency, etc. Moreover, you can create a QBank block just by a specific topic. For example, today I made a QBank about tuberculosis and another block about influenza. Each question provides answer and explanations. Very good. Many of them have creative summary tables, just like the one that I've showed you about hereditary cancer syndromes. The analytics are solid and the explanations have mnemonics. Look at that, I just created a block about the topic of influenza. As you see, the average is 55% because these questions are not for the faint of heart. If I showed this score to my Egyptian mother, she will say, "Hey Medicosis, why not 100th percentile? When are you ever going to get your act together? Go read a book, son." I love my mother. Many of the questions have mnemonics embedded in them. For instance, you could be answering a question about Campylobacter jejuni, and in the explanation you can click and it will play a video on Campylobacter jejuni picmonic. Look at the corkscrew appearance, the ascending paralysis of Guillain-Barré syndrome, King Arthur for arthritis, the bloody toilet for bloody diarrhea. TrueLearn and picmonic together is a match made in heaven. So what are you waiting for? Use the link in the description to try TrueLearn for free. If you want to subscribe, use promo code MEDICOSIS to get a discount or simply click on the link. Thank you TrueLearn for allowing me to share these questions with my students. And thank you everyone for watching. Please don't forget to subscribe. You can use this link to go to picmonic and this link to subscribe to TrueLearn. And when you answer many questions, please send me an email and tell me what's your percentage and what's your percentile. I will be your accountability partner and push you forwards. Learning is fun. Don't forget, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense. And TrueLearn, where vignettes will actually make you think and master your craft. We'll see you in the next video. Click on the link below.